Well, welcome to the 2020 Kentucky Perinatal Association meeting. I'm sorry that we're not at Lake Cumberland, but circumstances are what they are. We're going to provide these lectures on video and then combine them all together and still have a good educational experience for you. I'm going to lecture today on preeclampsia, specifically on the pathophysiology, diagnosis, management, and prevention of preeclampsia. And this is part of a 2020 perinatal series, and it's presented on behalf of multiple continuing education partners of the KPA. Now, for transparency's sake, I want to point out that I have some research support by a few of these companies. 3 of these are for biomarkers of preeclampsia, none of which have FDA approval, and I'm not going to discuss them during the lecture. The 4th company, Memento Pharmaceuticals, is on a treatment of Rh disease, and obviously I won't talk about that today as well. So the learning objectives discuss the pathogenesis of preeclampsia, and then we're going to spend most of our time reviewing the most current recent ACOG guidelines on the terminology, diagnosis, and management of gestational hypertension, preeclampsia, preeclampsia with severe features, superimposed preeclampsia and chronic hypertension, and then lastly review some of the potential strategies for prevention of recurrent preeclampsia. Now, preeclampsia is a disease unique to human pregnancy, and one of our problems in studying preeclampsia is we don't have an animal model. There are spontaneous hypertension rat models that are good for chronic hypertension, but not really for preeclampsia. In general, preeclampsia is going to be a new onset of hypertension, usually beginning after 20 weeks of pregnancy. Clearly, if untreated, preeclampsia can lead to serious, often fatal complications, such as hepatic hemorrhage or intraventricular hemorrhage. And unfortunately, the only cure we have at this point is delivery. And that's fine if the disease happens at term, but the more remote from term we are, the greater the consequences to the mother and particularly to the newborn. So we have a great objective measurement of preeclampsia, and that's hypertension, but clearly preeclampsia is more than just hypertension. It's a multi-system disorder. The blood pressure elevations can be mild or severe. Typically we talk about proteinuria with preeclampsia, and that's a consequence of capillary leak. It could be proteinuria, it could be pulmonary edema, it could be ascites. And then starting in the 1980s, this thought about the fibrinolysis and hemolysis with HELP syndrome, thrombocytopenia, renal failure. And then more recently with the 2013 Hypertension and Pregnancy Task Force, we pushed the importance of symptoms. Just because you don't have proteinuria or you don't have HELP syndrome, patients with persistent epigastric pain, severe headache, nausea and vomiting, these can be a component of preeclampsia and should be part of the diagnosis. From a fetal and neonatal standpoint, there are certainly risks for this disease. There's risk for growth restriction and preterm delivery because of abnormal placentation, because of reduced blood flow to the fetus, reduced amniotic fluid volume. There are risks for stillbirth, there are risks for neonatal death, and there's a significant risk for the placenta to try to come loose prematurely with a placental abruption. And all of these have potential long-term consequences for the neonatal outcome. So there are several theories as to why preeclampsia occurs. One is that we know it's a placental disease. You actually don't have to have a fetus to have preeclampsia. You can have postpartum preeclampsia when the fetus is already delivered. You can have preeclampsia from a molar pregnancy where there isn't a fetus. So the problem with the placenta is the spiral arteries don't invade properly into the myometrium. And in this slide you can see in a normal situation the spiral arteries move from the myometrium through the endometrium. But during a normal pregnancy, this invades through the endometrium to the myometrium. But for some reason with preeclampsia, there's shallow trophoblastic invasion, and it doesn't quite reach the myometrium. So essentially you're changing the flow of blood and the velocity of blood in these patients that have preeclampsia. We also know that preeclampsia is an endothelial injury. This is a patient that we took care of years ago and actually thought she had a cardiomyopathy, did a heart biopsy. You don't have to do heart biopsies to prove preeclampsia. But after she delivered, she developed proteinuria, elevated blood pressure, and it was obvious it wasn't a cardiomyopathy, it was preeclampsia. And the damage to these vessels, the endothelial swelling and blebbing that we see in this biopsy from the heart, we've also seen in skin biopsies, placental bed biopsies, kidneys and liver. So some function of preeclampsia damages the endothelium, and instead of having this nice circular endothelial layer, you have narrowing of those vessels that results in hypertension and the abnormal peripheral smears you can see with HELLP syndrome, where you see schistocytes and burst cells. Now, a more recent theory on preeclampsia is that there's some imbalance in angiogenesis. So a normal pregnancy is associated with a proangiogenic state, and for some reason preeclampsia is associated with an anti-angiogenic state. We're not developing these new vessels, we're not promoting improved blood supply to the placenta. So this imbalance can be seen even as early as the second trimester. So in a normal pregnancy, we have a balance between the pro and anti-angiogenic components. So PLGF is placental growth factor, and VEGF would be the anti-angiogenic. So in a normal pregnancy, we have a balance, and we have a healthy endothelial cell. So this maintains vascular tone, maintains the blood-brain barrier, we have an anticoagulant state, and we promote good maternal and fetal outcomes. In preeclampsia, for some reason, we have an imbalance. We have more anti-angiogenic, we have less proangiogenic, which results in this endothelial cell injury, which results in hypertension, proteinuria, the classic findings of preeclampsia, and it can be manifest even with cerebral edema and abnormal liver function tests. Now, this was data from the CPEP trial, Calcium to Prevent Preeclampsia, and they went back and actually looked at VEGF or SFLT, and you could see that SFLT increases as you develop earlier and more severe preeclampsia, and just the opposite, the PLGF, the placental growth factor, is reduced as you have earlier disease and more severe disease. So this imbalance can be used as a diagnostic treatment and a diagnostic therapy for preeclampsia. So recently, this is a paper we published earlier this year, we looked specifically at PLGF, not only with those with preeclampsia, but without preeclampsia. And the interesting thing is, the lower your PLGF level, implying poor placental function, the greater your likelihood to be delivered soon thereafter. Now, for preeclampsia, it was faster than non-preeclamptic, whether that PLGF level was extremely low, or even normal. But what we found from this study is that it's a good marker for preeclampsia, but it's actually a great marker for adverse perinatal outcome. So the consideration is, could this be used as a diagnostic or screening test, not only for preeclampsia, but for adverse perinatal outcome? And we have some further studies planned to do that. Now, we made a point earlier that preeclampsia really is a clinical diagnosis. We don't have a definitive diagnostic test. We have lots of efforts into this area. But if someone is pregnant and I want to confirm that, I can send off a beta-HCG. If I want to diagnose pneumonia, then I have a chest x-ray, diabetes with glucose monitoring, myocardial infarction with a troponin 1. But we don't have that same diagnostic test for preeclampsia. We rely on clinical information. So, gestational hypertension, the development of hypertension after 20 weeks gestation in someone that was previously normotensive. Traditionally, this has been a systolic greater than 140 and or a diastolic greater than 90. But in reality, when we reviewed this through the Hypertension Pregnancy Task Force, if it's and or, it might as well be or, and that's why we switched it to or. that's for without severe features. Severe features would be a blood pressure greater than 160 or a diastolic greater than 110, persistent for 4 hours. But we didn't want someone to hang out with a blood pressure of 160 over 120 for that 4 hours to make the diagnosis. If they required acute antihypertensive therapy because of the severe disease, they didn't need to have that persistent for 4 hours. And then by definition, the blood pressure should return to normal by 6 to 8 weeks postpartum, because if it doesn't, then this really was unmasked chronic hypertension. So what's the difference between gestational hypertension and preeclampsia? Preeclampsia is gestational hypertension plus something else. Traditionally, that was proteinuria defined as more than 300 milligrams of protein a day, or a PC ratio of greater than or equal to 0.3. But what we realized is maybe 10 to 15% of patients don't have preeclampsia, but certainly have clinical manifestations worrisome for that. So we've added in thrombocytopenia, impaired liver function tests, renal insufficiency, pulmonary edema, persistent cerebral disturbances, or visual impairment. This plus gestational hypertension would equal preeclampsia. As far as superimposed preeclampsia, we have someone that starts with chronic hypertension, either with a pre-pregnancy diagnosis or they have hypertension documented prior to 20 weeks gestation. So superimposed would be chronic plus any of the following: new onset proteinuria, a sudden increase in pre-existing proteinuria, or a sudden increase in blood pressure that was previously well controlled or requiring escalation of their blood pressure medications or even addition of a second and third agent. Then severe features would be chronic hypertension with superimposed plus severe hypertension that we can't control despite increasing blood pressure medications, usually maximum doses of 2 agents. Again, thrombocytopenia, impaired liver function, new or worsening renal insufficiency, pulmonary edema, or the persistent symptoms, either vision or headache. Now, I'll admit that there was a minor oversight with the Hypertension and Pregnancy Task Force, and that was with severe gestational hypertension. We implied that severe gestational hypertension equaled severe preeclampsia, but didn't specifically say that. But the ACOG Practice Bulletin in 2019 clarified this and said basically that severe gestational hypertension should be considered equal to preeclampsia with severe features. So this is blood pressure greater than or equal to 160 over 110 after 20 weeks gestation. Now, we think of gestational hypertension not being as severe as preeclampsia because you don't have the other manifestations of proteinuria or symptoms. But I'm showing 3 different studies here: Sudan from England, our work from here in the US, and then Laura McGee's work from Canada. And the earlier you develop gestational hypertension, the greater your likelihood to progress on to preeclampsia. And you can see in our data, if your diagnosis of gestational hypertension was less than 32 weeks, there was a 50% chance that you would ultimately evolve to preeclampsia. And of that, about 11% evolved to a severe manifestation of preeclampsia. The Canadian work, slightly less than that. So gestational hypertension, remote from term, is not mild disease. It has potential for evolution to preeclampsia or severe disease. Now, how do we decide once these patients are diagnosed with preeclampsia or gestational hypertension, when is the optimal time for delivery? Traditionally, we would wait till 39, 40 weeks, wait for a favorable Bishop score. But the HIPPOTAT trial published in 2009, this was in the Netherlands, really gave us better information to make decisions from. And the HIPPOTAT was basically induction of labor versus expectant monitoring for gestational hypertension or mild preeclampsia after 36 weeks. And this was a randomized trial, again, mostly in the Netherlands. And you can see that they randomized 377 to the immediate induction versus 379 to the expectant management. The average gestational age was a bit past 38 weeks. About 2/3 in each group had gestational hypertension, about 1/3 had preeclampsia. Proteinuria, fairly similar. One of the concerns in inducing these patients with a poor Bishop scores was were we artificially increasing their risk for cesarean delivery. So you can see that in this study, approximately 1/4 of the patients had a Bishop score less than 2, and about 2/3 of the patients had a Bishop score of 2 to 6 when they were randomized. But the data clearly showed that the induction group had a lower composite adverse outcome compared to the expectant monitoring group. And predominantly this was from the development of severe systolic hypertension. And you can see that this was 15% versus 23%, and the relative risk was 0.63, and the confidence interval did not cross 1. There was a trend towards a lower C-section rate despite these poor Bishop scores in the induction of labor group, albeit the confidence interval did cross 1, so therefore not statistically significant. But clearly we did not increase the risk for C-section in the induction group even with the poor Bishop score. So I think from a maternal standpoint we can say that induction was beneficial. The question is, was there a neonatal difference? And the answer is there was not. So if there's not a neonatal benefit for prolonging the pregnancy and there's a maternal benefit for induction, then that's the conclusion of HIPPOTAT 1. HIPPOTAT 2 was performed it was published in 2015, and it specifically asked the same question, but at a gestational age of 34 to 37 weeks. And what they found in that group, again, a little over 300 randomized to each arm, but in the immediate delivery group, the composite maternal adverse outcome was 1.1%, for the expected management 3.2, but again you can see that the confidence interval crossed 1, so that even though there was a difference, it wasn't a statistically significant difference. However, when we look at the neonatal outcomes, clearly there was more adverse neonatal events in the immediate delivery group. And this is largely respiratory distress, 5.7% versus 1.7%. And you can see that the confidence interval did not cross 1. So the conclusion from HIPPOTAT 2 was that immediate delivery did not significantly decrease the risk for adverse maternal outcomes, but it did significantly increase the risk for neonatal respiratory distress syndrome. So the conclusion from HIPPOTAT 2, women with and this was non-severe, these are patients we used to call mild, but now we call non-severe, hypertensive disorders between 34 and 37 weeks should be continued to be monitored conservatively and monitored expectantly. Now, some of the criticisms of this paper, does mild RDS equal eclampsia or HELP syndrome? But again, from the conclusion, currently the thought is continue conservative management 34 to 37 unless you have development of severe manifestations. So for an algorithm for management of gestational hypertension or preeclampsia, and this is without severe features, the first goal should be maternal and fetal evaluation. So with the maternal evaluation, if the gestational age is greater than 37 weeks per HIPPOTAT 1, we should move to delivery. If you're past 34 weeks and you have evidence of labor, rupture of membranes, poor fetal growth, again, proceed on delivery. If the fetus, I make the point that I think fetuses can direct their own destiny. And if you have rupture of membranes, if you have spontaneous onset of labor, with preeclampsia, there's concern that there's a hostile intrauterine environment, and would this baby be best served with delivery? And I think the answer is yes. Certainly if you suspect an abruption, or if you have some abnormal maternal or fetal testing, then those patients are best served with delivery. If the mother and the fetus are stable, then the issue becomes, can we prolong the pregnancy safely, and does that need to be inpatient or outpatient? And I think we, in multiple previous publications, have shown that outpatient is reasonable with reliant patients that are seen frequently in the office for testing. So if we have worsening maternal or fetal condition, spontaneous labor, rupture of membranes, or the achievement of 37 weeks gestation, then again, these patients are best served by delivery. Now, what about for severe features? This would be gestational hypertension or preeclampsia, blood pressures 160 or 110, 4 hours apart while at reduced activity. Or, again, if you require an acute antihypertensive to treat a severe range blood pressure, that would put you into severe features. With that, we look at different manifestations. Do they have persistent severe headaches or visual disturbances, the development of pulmonary edema, right upper quadrant pain that's persistent that makes us worry about stretching on the liver capsule, elevated liver enzymes. And I'll admit there has been some issue about what constitutes an elevated liver enzyme. When you look at the original hypertension pregnancy task force, some places it was listed as 2 times normal, but in actuality, what was meant was 2 times the upper limits of normal for your lab. So if the upper limit of normal of AST for your lab is 35, then anything over 70 would be considered abnormal. We were uniform about the definition of thrombocytopenia in pregnancy less than 100,000, and then a serum creatinine that doubles or the value is greater than 1.1. All of these would meet severe features for preeclampsia. Now, what about the trends for preeclampsia? And overall, the trend for preeclampsia has been the same really for the last 30 or 40 years, and particularly the same for those without severe features. But I think you can see from this slide that there's been a gradual increase in the number of patients with severe preeclampsia, and there are a variety of hypotheses for why this is occurring. Clearly, patients are bigger now. We see a lot more obesity than we did 30 or 40 years ago. We also see less smoking, and we know that tobacco smoke clearly reduces the risk for preeclampsia. You say, well, that doesn't make sense. Well, it does because for a variety of things. One, the patients that smoke tend to be smaller, and there's no doubt that a lower BMI carries a lower risk for preeclampsia. And there also may be some function of nicotine working against the anti-angiogenic factor. So virtually every study that's looked at it, smoking does reduce the risk for preeclampsia. The downside is if you smoke and you do get preeclampsia, you carry much higher risk for abruption. So I'm not going to recommend smoking for reduction of risk of preeclampsia. And older mothers. We have more patients that are over 35 that have underlying medical issues and clearly have a higher association with the risk for severe preeclampsia. Now, the classic teaching, if you go back and pull out a Williams obstetrics from 30s, 40s, 50s, even 60s, the sun should not set on severe preeclampsia. Once you make the diagnosis, you should proceed on with delivery. And from a maternal standpoint, there's no doubt that that's a great idea. But delivery is not good for that extremely preterm infant. So we have to balance between the fetal and maternal risk versus the newborn benefit. Can we safely prolong the pregnancy to make a benefit for the newborn? Babies born between 24 and 28 weeks gestation carry significant risk for complications because of respiratory distress, chronic lung disease, risk for chronic heart disease, hearing and visual disturbances. Cerebral palsy rates may be in the 10 to 15% range, and then other neurologic disabilities for these very preterm babies. So, an algorithm for management with severe preeclampsia or severe gestational hypertension. This is based on ACOG and SMFM. If you are below the limits of viability, and that depends on where you are in this country or on this planet, in general, less than 23 weeks, we would consider that to be pre-viable and would not consider conservative management. This is particularly true if you have a gestational age at less than 23 and growth restriction. You already have a hostile intrauterine environment. From data we published several years ago, we didn't have survivors when we had growth restriction and new onset severe preeclampsia less than 23. The data would also support that after 34 weeks, there's limited newborn benefit but significant maternal risk. So is it worthwhile to take this maternal risk for no added newborn benefit? So our thought now is that if you're below the limits of viability or past 34 weeks gestation, these patients receive magnesium sulfate for anti-seizure prophylaxis. We stabilize them by improving their blood pressure, and we move towards delivery. If they're in that middle window between 23 and 33 and 5, then it's reasonable to admit those patients to the hospital, give them steroids for fetal lung maturity enhancement, provide magnesium sulfate for anti-seizure prophylaxis while you're evaluating, do they have persistent severe disease, do they need to be delivered, or can we temporize them and potentially prolong the pregnancy? And then while they're in the hospital, it's reasonable to give antihypertensive agents to keep them out of a severe range. You don't want to make their blood pressure normal, you want to make their blood pressure safe. Then, if they reach a term gestation, if there's maternal indications for delivery or fetal reasons, then we proceed on with delivery. Now, there's been a thought, or there was a thought, that preeclampsia accelerated fetal lung maturation, so these babies really didn't benefit from the steroids. But I think this study from South America clearly showed that there is a benefit. This was a randomized study between 26 and 34 weeks gestation, placebo versus treatment with betamethasone. And you can see overall for respiratory distress syndrome, clearly a benefit. The relative risk was 0.53, confidence interval did not cross 1. For severe respiratory distress, a clear benefit. Even as late as 33 to 34 weeks gestation, there was benefit. But the other thing that we've seen with steroids is not just improving lung maturation. By having better lungs, we reduce the amount of ventilation, we reduce the risk for intraventricular hemorrhage, infection, and even death. So even though we think that preeclampsia may be accelerating lung maturation, these are women and babies that would benefit from steroids for lung maturation. So, current management of severe preeclampsia less than 34 weeks. These are patients that need to be admitted to labor and delivery for 24 to 48 hours. You know you have one point on a curve to say that their pressure is elevated. Is it continuing to elevate? Is it a transient elevation that will improve with reduced activity? We don't know, so we need more information, but the best place to gain that is on the labor and delivery unit. These patients should be placed on magnesium sulfate prophylaxis to avoid seizures, and there is some thought that if they're less than 32 weeks that they get a benefit for neuroprotection. They should receive steroids for fetal lung maturity enhancement, antihypertensive agents for severe range blood pressure, and your goal is not for a normal blood pressure, but a safe pressure. It may be that the blood pressure is up because of poor placentation and the fetus needs this extra blood pressure to maintain perfusion. And by over titrating your antihypertensives, you can result in fetal distress. These patients need ultrasounds to assess for estimated fetal weight to make sure there's not growth restriction, assessment of Doppler to evaluate their placental function, and then biophysical profile, because often when these babies are remote from term, they're not going to meet the 15 by 15 criteria for reactivity. They may have reduced beat to beat variability. The fetal heart rate may not be as predictive of well-being. They need daily monitoring of their symptoms, vital signs, more than daily, usually every 4 hours initially. Laboratory tests daily for the first few days to make sure that they're not having thrombocytopenia, elevated liver enzymes, or change in their renal function, and then delivery for maternal or fetal indications. Now, I hope no one in this audience thinks that this tracing is reassuring. There's absent beat to beat, there are no accelerations, you have recurrent decelerations. Clearly this is not a fetus that deserves conservative management, it deserves immediate delivery. One of the reasons we do Doppler studies is to assess placental function. And you can see in this picture that this is persistent reverse diastolic flow. A paper we published several years ago looked at the likelihood of successful vaginal delivery with preeclampsia and reverse diastolic flow, and essentially it was 0. We had one person that delivered, but they were 18 weeks and we weren't monitoring. Typically, these are patients that you would start a labor process and they would achieve regular uterine activity and then have non-reassuring tracing. So in general, someone remote from term with severe preeclampsia and reverse diastolic flow, not in labor, poor Bishop score, I would just section out right. So fetal guidelines for delivery, and this is within the first 72 hours. If you have non-reassuring status, either by the fetal heart rate tracing or a persistent biophysical profile of 4 or less, that's an indication for delivery. Within 72 hours, you can make a case for trying to buy steroids for fetal immaturity enhancement. Amniotic fluid, traditionally we've used an AFI of 5 centimeters, but I think what we're seeing is that if you have a deep but thin and narrow pocket, probably the better predictor is, do they have a 2 by 2 centimeter pocket? Estimated fetal weight less than the 5th percentile with significantly abnormal Dopplers, you're not going to gain more than 72 hours. These are indications for delivery, as would be labor or rupture of membranes. And again, as we talked about before, the achievement of 34 weeks gestation. There is not enough added newborn benefit to counteract the significant maternal risk you take after 34 weeks. And one of the big risks is abruptio placenta. Cocaine is one of the highest risks for abruption. Second would be rupture of membranes, but third would clearly be hypertension. And in most of the data for conservative management of preeclampsia, severe preeclampsia, remote from term, you're looking at abruption rate of 6 to 7%. Pulmonary edema we've talked about before, and this would not be related to iatrogenic fluid overload. But I think it's very important to use your fluids in a judicious manner, not giving a lot of salt, not giving a lot of fluid. Because of these leaky capillaries, they are prone to pulmonary edema. Now, patients have cerebral manifestations with preeclampsia. And you ask, well, why are we focusing so much on cerebral manifestations? And often it's visual because the posterior aspect of the brain is more prone to changes with preeclampsia than the anterior, because the carotids to the anterior brain are under different innervation than the cerebral vessels to the back of the brain. So posterior reversible encephalopathy, you have vasogenic edema in the occipital area, which is the visual area of the brain. You can see here magnified. In the obstetrical literature, this is Press. In the neurologic literature, this is Call Fleming. But it's reversible. Once these patients are delivered, treated with magnesium sulfate, within a couple of weeks, most of this goes away. One of the more feared complications of severe preeclampsia is right upper quadrant pain that results in rupture of the subcapsular hematoma. So you can have bleeding under the capsule, and as long as the capsule is intact, it provides tamponade and avoids heavy bleeding. But once that capsule ruptures, you're looking at massive hemorrhage. We have one case that the patient required over 100 units of blood and blood products and transfusion. I'm aware of a case in Denver of over 1,000 units of blood and blood products. So this is why we ask about the right upper quadrant pain. This is why we monitor the liver function tests. So what do we consider contraindications for continued expectant management? Certainly eclampsia. If a patient has had a seizure, in the few randomized studies that have looked at this, you're so unlikely to gain extra time. It's not worth the risk for trying to delay the pregnancy for steroids for lung maturity enhancement. We've talked about if you're below the limits of viability, and again, this has to be individualized based on your NICU, which country. If I was in Africa, I would say 28 weeks, not 23 weeks. The presence of acute renal failure, HELP syndrome, abruption, some abnormal tracing, or the achievement of 34 weeks gestation. Any of these would be considered a contraindication to continued expectant management. Now, there's a lot of debate about what constitutes HELP syndrome, and I see a lot of patients in their chart, particularly when we review these, listed as HELP. But Sabine criteria from the early 80s, and those really reinforced by the Hypertension and Pregnancy Task Force, you need the 3 components. Hemolysis, which could be an abnormal peripheral smear. Remember back to our endothelial damage, we've narrowed that vessel. As those red cells move through, you get schistocytes and burst cells. from a laboratory evaluation, an LDH greater than 600 or a bilirubin greater than 1.2. Elevated liver enzymes, 2 times the upper limits of normal. So for most labs, about 70 for an AST or an LDH greater than 600. And then a platelet count less than 100,000. So to have true HELP syndrome, you need all 3. If you have the first 2, then you have HEL. If you have the last 2, you have ELP. If you don't have any, then you don't have HELP syndrome. So I think it's important to be uniform in our diagnosis, particularly if we're following the outcome for these patients. But clearly, once you meet HELP criteria based on the SABI criteria and the ACOG criteria, significantly increased risk for early delivery, pulmonary edema, and the development of eclampsia. So he previously used a criteria of 5 grams of protein per day to differentiate between severe and non-severe preeclampsia. John Marshall Harlan is one of my fraternity brothers from Center College, graduated a few years before me, but he was the lone dissenting vote in the Plessy versus Ferguson decision, and that was separate versus equal. And Harlan had made decisions before that it was okay, but then when it went to the Supreme Court and he was on the Supreme Court, he was the lone dissenting voice. And someone said, well, how can you change your mind on this? You've always voted this way. And he made the comment, let it be said that I'm right rather than consistent. And we at ACOG for the Hypertension and Pregnancy Task Force really decided to do the same thing. The original data for 5 grams was completely made up. It was a bunch of guys in a bar in Dallas at the International Hypertension and Pregnancy Convention. It was not based on data. And since then, we've had multiple studies to show there's no difference in outcome, whether you're less than or greater than 5 grams. Outcomes were similar, even if you're up in the 10-gram range. So we took that out as a criteria. Your decision for delivery should be based not on the amount of protein or change in proteinuria. And in addition, once you prove that the patient has significant proteinuria, meaning more than 300 milligrams a day, you don't need to do repetitive 24-hour urine studies. You've got the diagnosis, and it doesn't matter whether it's 1, 5, or 10 grams from thereafter. Now, I show the picture here of Secretariat, winner of the Triple Crown in 1973, but you'll notice that he has blinkers or blinders on. And blinkers or blinders are great for a horse to force it to focus on the oncoming track. But it's not good for those managing preeclampsia. You have to keep an open mind. It can't be that I'm getting to 34 weeks, I don't care what happens. And I think that's why I bring this slide up. This is data from Laura McGee, over 4,600 patients that had expected management of preeclampsia. About 40% of the time, maternal indications pushed for delivery, fetal about 36% of the time in her data, a combination of the two in 9%, spontaneous labor in 6%, achievement of a gestational age of 34 or greater at 16%. So it has, and what I always tell the residents and what I tell patients, when we're monitoring somebody with expectant management, every day that I see them, I ask 3 questions. How is the mother? How is the baby? How far along are we in the pregnancy? If we're far enough along that the baby is best served by delivery, then we move to delivery. If there's maternal compromise or there's fetal compromise, we deliver. Otherwise, we can continue our expectant management. Automated blood pressure measurements have made it much simpler for the nurses to take and document blood pressure. The downside to an automated blood pressure cuff, however, is it gives you a number regardless of the maternal position, the cuff size, whether or not the patient is having contractions, whether or not she has an epidural, whether she's pushing or not. And in modern management, particularly for someone that's undergoing an induction of labor, it's not uncommon that these patients can have more than 50 blood pressure readings during their time on labor and delivery. And as we do more blood pressures, and if they're not done under a controlled situation, often we're going to see some of these values as elevated. This was a study published earlier this year out of Houston, where they looked at 724 women, had no history of hypertensive disorders. Yet 1/3 of them had some documentation of mild hypertension during their labor and delivery stay. 10% of those were severe, but only 6% of those 69 that had severe range actually received an IV antihypertensive agent. So it's important that we're, one, monitoring blood pressure, and two, acting on it if it's significantly elevated. So why do we treat severe hypertension? We want to reduce the risk for intraventricular hemorrhage, reduce the risk for encephalopathy or heart failure. But we have to be careful. It's a balancing challenge. We don't want to lower the blood pressure so much that we cause fetal distress or ischemia to the brain or the liver. So how should we do this from a clinical standpoint? So we've agreed that for antepartum patients, a systolic blood pressure greater than 160 or diastolic greater than 110 is abnormal. So if we get that reading, the burden is on us to let's check the patient's position, make sure that the cuff size is appropriate and it's positioned in the correct place on her arm, that it's at the level of the right atrium, that her legs are uncrossed, she's not in pain, she's not in uterine activity, not having uterine activity, and then repeat that blood pressure in 15 minutes if we've satisfied all the criteria. If we're still above that target, then order the antihypertensive agent, but reassess the blood pressure before we administer it. When you looked at some of the original data from ACOG 10, 15 years ago, treat immediately but within 60 minutes. Well, immediately means 1 minute. And I think realistically, your goal should be to treat these severe range pressures within 30 to 60 minutes. Now, the caveat I would have for your cutoff for antihypertensive therapy, if you have thrombocytopenia, your platelet count less than 100,000, congestive heart failure, or the patient is postpartum. A postpartum patient doesn't have a placenta, we're not worried about reducing placental blood flow, then I would cut your target back to 150 systolic, 110 diastolic, or a MAP of 115. So as far as acute control of severe hypertension, 3 traditional medicines for doing that. I think labetalol has probably shown the most consistent reduction in blood pressure, particularly useful if there's also underlying tachycardia. In general, we use the protocol of Bill Mabey. Labetalol comes IV in a vial of 300 milligrams. So we give 20, 40, 80, 80, 80, separated by 10 minutes, and that would use up the whole 300 milligram vial. The one contraindication you really need to be aware of is asthma. There is a case report from Mary Dalton out of New York. A patient actually died from status asthmaticus when treated with labetalol for severe hypertension. We've also in the past used hydralazine, which is a good medicine for lowering blood pressure. I would start with a dose of 5 milligrams and then move up in increments of 10 milligrams every 20 minutes. The downside to hydralazine, about half of people in America are fast acetylators, the other half are slow acetylators, and you don't know who is who. So you can get this stacking effect. You give several doses of hydralazine, it doesn't seem to work, and then boom, all of a sudden you crash their pressure down. If you don't have IV access, oral nifedipine is a great therapy for severe hypertension. Don't do it sublingual. Don't have them bite the capsule. Have them swallow the capsule. 10 to 20 milligrams every 20 minutes for a maximum of 60 milligrams in that first hour. And for those that have severe hypertension that we're not able to control this way, then certainly we can use IV sodium nitroprusside. As far as postpartum management of preeclampsia, those with severe disease need to be monitored for a minimum of 72 hours. They don't need to be sent home and come back for a 6-week postpartum check. They really need to come back in 7 to 10 days or be evaluated by some home health agency or in a clinic. The thing that we've really pushed for is that these are patients that should receive written discharge instructions, that a headache is not necessarily normal postpartum. It could be a sign of preeclampsia. Right upper quadrant pain, chest pain, vision impairment. And on that written discharge instruction, an office number and a number to the labor and delivery so that they can call if they're unsure. For a variety of reasons, we've had an increased incidence of late postpartum preeclampsia and late postpartum eclampsia. One of the thoughts is that so many patients are getting epidurals, they get fluid with the epidural, are they having this delayed diuresis, which increases their risk for exacerbation of hypertension postpartum. But they need to be evaluated and treated, preferably through labor and delivery, not through the emergency room. So, prevention of preeclampsia. The only true prevention we have is birth control, but that's not very good job security for obstetricians. So, what works? What do we have that we can give to prevent preeclampsia? We've looked at different antioxidants, vitamin C, vitamin E, different antihypertensive agents, nifedipine, labetalol, Aldimed, nutritional supplements like fish oil, magnesium, calcium, and platelet agents like low-dose aspirin. I guess the question is easier to answer: what doesn't work? Calcium supplements don't reduce preeclampsia in a developed country like the U.S. In the third world countries with low calcium intake, potentially beneficial. Fish oil was tried because the lowest incidence of preeclampsia in the world is in Scandinavian countries that eat a lot of deep sea fish. No benefit. Vitamin C and vitamin E not only did not prevent preeclampsia, they were associated with some adverse perinatal outcomes. Magnesium and zinc don't work. The problem with magnesium, by the time you ingest enough magnesium to get a decent serum level, you have profound diarrhea. Think about mag citrate. The antihypertensive agents do reduce blood pressure, but they don't change the ultimate need for delivery for preeclampsia. Garlic doesn't work. Metformin may reduce weight when used, and with a lower weight you have a lower risk for preeclampsia, but in and of itself didn't prevent. Some of the agents like Viagra have been used with preeclampsia and growth restriction, highly correlated with fetal loss. And then recombinant antithrombin, the paper for that is under review, but it didn't show any benefit. So we've been using low-dose aspirin for over 40 years. There's still some debate about when to start, how much to give, but the U.S. Preventative Services Task Force about 5 years ago said, look, if you have an underlying risk for preeclampsia of more than 8%, we think the drug is safe and we think it has potential benefit, therefore you should receive it. So those with prior preeclampsia, multifetal gestation, chronic hypertension, pregestational diabetes, renal disorder, autoimmune disorder, or any combination of some moderate risk factors that takes your background risk to 8%, low-dose aspirin therapy. In the US, we're using 81 milligrams. There's still some debate about should we use more for obese patients. And in general, if you're thinking that this is going to work on placentation, then starting at 12 weeks makes a bit more sense than the European data starting up to 20 or 24 weeks. Now, there's lots of research ongoing as far as ways to treat preeclampsia. I talked about the antithrombin 3 trial. I was part of this. It's an interesting thought that the Japanese literature shows that there is a reduction in antithrombin 3 in those with severe preeclampsia. But one of the things, going back and looking at their data, their average BMI for their patients was less than 20, which is certainly not what we see in America. But in this randomized study, there was absolutely no benefit for the antithrombin 3. It was derived from transgenic goats, and their goat milk expressed antithrombin 3. But that study spent over $40 million to show no benefit. It's under review from the Gray Journal and should be published in the next few months. The Digibond trial was having a very difficult time recruiting patients during COVID. They did an interim analysis, absolutely no benefit, and that was a trial that probably spent over $20 million. There is some thought about dextran sulfate cellulose removal of S-FLT. The problem is, if you're removing S-FLT, are you also removing other important biologic mechanisms? The Viagra did not work well, particularly in growth restriction. The Nexium study out of South America and Australia, no benefit. So again, a lot of effort, a lot of money, but really nothing more than low-dose aspirin. So as a final slide, practical suggestions. Well, number one is don't have sex with the wrong guy on the first date. And every good parent would make that point. And the reason I make it specifically is the longer you cohabitate with someone, the more acclimated you become to their DNA, the lower your risk for preeclampsia. It's called the Robillard theory. So you really prefer to have non-barrier method of contraception for at least six months, so you're exposed to the paternal DNA. When you think about what are the highest risks for preeclampsia, donor egg, donor sperm, donor embryo, because you've not seen that DNA before. And that's an important point in counseling. If you have a patient that's undergone IVF with donor egg or donor sperm, they run maybe as high as 35 to 40% risk for preeclampsia. Folic acid doesn't specifically reduce the risk for preeclampsia, but overall it's a good preconceptual idea. Low-dose aspirin in the select patients starting at 12 weeks. There's no doubt that the higher your BMI at conception, the greater your risk for preeclampsia. So if you're seeing someone preconceptually, encourage that weight loss. And there's actually good data now that people that undergo gastric bypass and are successful carry a lower risk for preeclampsia with their weight loss. And then those that have pregestational diabetes, the better your glucose control, the lower the risk for preeclampsia. So finally, I'd like to thank the audience for being members of the Kentucky Perinatal Association and being part of this conference. There are the 2020 perinatal series will be completed hopefully in the next few months, and this will be our substitute for going to Lake Cumberland. And you can see some of the course offerings that will be available. And certainly we want to thank our sponsors, Mead Johnson Nutrition, for their sponsorship of the Kentucky Perinatal Association. And finally, I'd like to thank the Kentucky Perinatal Association for their kindness in naming me as the recipient of the 2020 KPA Founders Award. But it's not really about awards, it's about rewards. And one of the greatest rewards is to have a patient come up to you and say, "You saved me," or "You saved my baby 10 years ago." It's even better when they say that in front of your wife or your kids, even though they roll their eyes and say, "Well, not another one of these." But as an educator, and this is one of the reasons that I do it, it's very rewarding for me as a healthcare professional if someone comes up and says, "Hey, I learned something from your lecture that saved a mother's life or a baby's life because I listened to what you said about preeclampsia or septic shock or abnormal placentation." And that's why our mission from the KPA is so important. It's to improve maternal and neonatal outcomes, to advance education, advance knowledge, so that we're taking care of the future of Kentucky. I thank you very much for your attention, and I wish you the best.